Hi, I'm Matt Collins, and today I'm going to be demonstrating and running through the appropriate management of a primary postpartum hemorrhage and continuing on from the video that we were shown earlier.
There are four causes of primary postpartum hemorrhage. These are known as the 4 T's: tone, trauma, tissue, and thrombin. Tone accounts for about approximately 70% of all cases, trauma 20%, tissue 9%, and thrombin 1%. The assessment of tone will be addressed further throughout this video. I will briefly talk about the three remaining causes. Trauma involves any sort of perineal tears that involve some external hemorrhaging which can be ceased with some direct pressure. Tissue refers to any part of the placenta that remains within the uterus when there is separation of the placenta from the uterine wall. When assessing the placenta to ensure that there's no retained placenta within the uterus, this is what you're looking for in the placenta, making sure that it's whole and it's complete and it's got nice smooth edges like the picture here.
In this situation with a significant postpartum hemorrhage, it's important to get Piper on the phone, and you can have them on speaker whilst at the scene to get any advice or any clinical guidance to assist you in any way you can for the patient. As per any job, I've got all my universal precautions on, my PPE, so I've got my gloves on and I'd have some glasses/goggles as well. For my patient that's suffering from postpartum hemorrhage and is complaining of significant bleeding, you always got to do a secondary survey and assessment of the area to ascertain if there is any bleeding and how much there actually is. So to do this, I would inform my patient that I'm going to have to pull away the towels I got here, and I'm going to have to expose her, and keeping the patient's dignity at the forefront of my mind. So explaining to her what I'm going to be doing. So I'm just going to be lowering down the blankets and making sure that the back doors are actually closed, and visually inspect the genital area and the perineum to make sure that there isn't any obvious trauma or tearing to the area. So as per any general care with pregnant patient, some high flow oxygen, and we're going to manage the patient's pain. She's obviously going to be in pain, and then because of significant blood loss in postpartum hemorrhage, so normal saline as per hypovolemia 20 mL per kilo. So I'm going to place a non-rebreather on the patient. And I've got my bag of fluid here already set up and attach that. And then titrate pain relief, morphine or fentanyl, probably fentanyl in this instance because of the hypotension, and titrate to getting some pain relief. So the first point of call in a primary postpartum hemorrhage is assessing the fundus. Ideally where you want it to be is to be below the level of the umbilicus, and to assess the fundus with this aspect of your hand, what you want is, for a firm fundus, you should be able to find defined edges, and it should only be this edge here of your palm and not the full length including your finger. And so you just roll your hand down like so, and if you can feel a fundus, it'll feel like a boggy type mass, and if you can feel along the full length of your hand, you know it's not firm. But if you can feel definitive edges and it's small, you know you've got a firm fundus.
When assessing the fundus to see if it's firm, this is what a firm fundus should feel like. And when assessing the fundus, a non-firm boggy fundus will feel like this.
Right.
Yeah, okay, go.
So I've assessed the fundus and I've ascertained that it's not firm, and so what I need to do is cut my hand like so, and a circular motion, just rub the fundus like this until I can get it to be firm. This is going to be quite painful for the patient, so I explain to the mother what I'm doing and why I'm doing it, and throughout I can keep giving pain relief to make sure she's pain free.
Talk about the nipples and urination.
That's right. That's
yeah.
oh.
So you have to cut it.
Yeah.
Just turn from going down, look up at the camera and say it.
So whilst massaging the fundus, I can also do some other management strategies to try and help firm the fundus up. I can get the baby to attempt to suckle on the patient's breasts, and I can also encourage the mother to empty her bladder, which also can assist in firming the fundus. So I've attempted to massage the fundus and firm it up. I've been unable to do that. So the first drug management I can go with is some misoprostol, and that's 4 200 mic tablets to a total of 800 mics, and that's orally. And also after that I can go with some Syntocin, 10 international units in 1 ml, and that's via an IM injection. Swab the area, sharp out, and sharp with the sharp bit. And with my 10 international units oxytocin, I can repeat that same dose at 5 minutes. So as a last resort, after my pharmacology for primary postpartum hemorrhage, is some external aortic abdominal pressure. So what I do here is just left of the umbilicus. I'm going to apply some pressure like so with my fist and try to occlude the abdominal aorta. This is going to be extremely painful for the patient. I need to explain to her what I'm doing and provide some pain relief at the same time.
The postpartum hemorrhage patient is a critical patient, and it's essential that the clinician looking after the patient is not afraid to make the call early. For postpartum hemorrhage, all you need to lose is 500 mils for postpartum hemorrhage to be ascertained. The blood vessels perfusing the placenta through the uterine wall, you can lose 750 mils a minute of blood. So for a patient that has already lost 500 mils that you've determined they got pph, or already to that critical point of losing 750 mils plus more before you ever make that decision. These patients are the ones that are essential that you fill them with fluid. You can't be shy, and you need to intervene early. Also with these patients, studies have shown that misoprostol and oxytocin in conjunction improve the reduction of bleeding post-pph. If there is any doubt with determining if you think it is pph and whether how much blood they have lost, it's always better to go with your risk versus benefit. The risk of giving a patient oxytocin is 0, but the benefit of giving someone oxytocin that is suffering from pph is significant. Don't be afraid. You've got to get in, give these people early IV access and early administration of fluids. Here is an overview of the guideline used by AV for pph. There are several options available for management of the pph in hospital. There's the intrauterine balloon, where the balloon's inserted and blown up to tamponade the area. TXA, which is shown to significantly decrease mortality and bleeding, and bimanual compression.